Ready when you are, Dr. Sennett.
It's my pleasure today to introduce Dr. Guy Handley. Dr. Handley has an enviable education. I think the most important part was his work in Texas at MD Anderson with immunosuppressed patients. He's now at doing research on Epstein-Barr virus. And these viruses, the DNA viruses, are intensely interested. They're obviously oncogenic, and they involve themselves with oncogenic patients. So when you look at lymphoproliferative disease, hemophagocytic lymphohistiocytosis, and Burkitt's, you really think about vascular lesions, but also gastric cancer and nasopharyngeal carcinoma involved, and it complicates the management of any other diseases. Guy, we look forward to you sharing your knowledge with us. We're thrilled. Thank you very much.
Yeah, thank you, Dr. Sennett. I can't say when I started ID fellowship, I was interested in herpes viruses, but I got kind of some exposure from a few of my mentors there, Dr. Pablo Aquisin and Rodrigo Hasbin, and it kind of took off from there. And now I just find them fascinating because they're just so omnipresent. And while most people don't have any complications from infections, they can be pretty disastrous and complex, certainly the more immunocompromised our patients get. Today, I'm just going to go through a lot about the Epstein-Barr virus. First half of the talk is mainly about general epidemiology, mononucleosis, HLH. And then the last half is moving more into kind of the realm of things that I'm hopefully going to continue looking at through research and working with immunocompromised patients in terms of lymphoproliferative diseases, its risk factors, treatment, and things like that. There's a few questions we'll have throughout the presentation using the Poll Everywhere software. You don't have to download it on your phone or anything. You can just use the link at the bottom, pollev.com, and that's the handle associated with it. I have no disclosures related to the talk. And we'll start with a question. So a 38-year-old male presents with acute myalgias, fevers, and a sore throat for 5 days. He has a 2-year-old and a 3-year-old child who attend daycare but are otherwise healthy. He's in a monogamous long-term relationship with his wife. On exam, he is febrile to 100.6 Fahrenheit, but hemodynamically stable. He appears well. He has no lymphadenopathy, tonsillar exudate, or rash. His labs are unremarkable except for lymphopenia, an AST of 150, an ALT of 180, and a peripheral smear is shown. And so the question is going to be, what is the most likely pathogen? And so with that, it should be open for you to be able to put in your response, and I'm going to try it as well just to make sure it's working.
The link is in the chat if you need it to the Poll Everywhere.
Yeah, it's also at the top too, just pollev.com, Guy Handley 812. And you can send a text if you prefer to use that one. I think we will, we have a few more questions later on, so don't worry if you didn't get a response in for this one. Pretty even split. So kind of wanted to make sure everybody's awake. I know it's around lunchtime. The answer is actually cytomegalovirus. This is a pretty challenging question. I'll admit I miss questions like this too, studying for my ID boards, and it's a favorite of the ID boards. Every single virus on this list can cause the presentation. And so what they're really getting at is certain risk factors and the age group of the patient. Those kind of things are going to point you one way or another. Things like HHV6 and 7, you're going to acquire those usually when you're very young, age 2 to 5. EBV, by the time you're around age 40, almost everyone's acquired it. And so those are unlikely. And another favorite thing of ID boards is that transaminitis is something more specific to CMV, mononucleosis than EBV. So it's a very challenging question, I'll admit, but it is one that shows up a lot of times on our boards because they want us to kind of pick out which of these viruses that can all cause a similar presentation or at play. So I'm going to go through the basic virology, latency, and epidemiology of the virus, discuss its various clinical manifestations or complications, including acute mononucleosis, HLH, and other lymphoproliferative disorders. We're going to go over the serologic testing, when to use it, the pitfalls, talk about any known therapeutics and areas of future investigation. It's a brief review. Each of these topics you could easily do a separate lecture on, and certainly have time at the end too for any questions because it is a pretty complex virus and has many manifestations. So the virus is actually also known as human herpes virus 4. It was first discovered in a patient with Burkitt's lymphoma. It's a gamma herpes virus, so it's the closest related to is actually HHV8. We have our alpha herpes viruses, HSV1, 2, and varicella. Our beta herpes viruses, CMV, HHV6 and 7, and then this is kind of a third grouping of viruses. There are 2 strains, but 1 species, EBV1 and EBV2. It's really just based off of different expression of latent cycle antigens and small encoded or encoded small RNAs. EBV1 predominates in the United States and Europe, and EBV2 is more commonly seen in Africa. But even in the United States in immunocompromised patients, there is a higher proportion of EBV2. The significance of that isn't fully understood. So the virus, initially, your primary infection occurs in oral epithelial cells. After that, the virus goes on to infect B lymphocytes and then establishes latency for the rest of your life in memory B cells. When you have symptoms, it's actually delayed substantially from the initial infection. It can be several weeks up to a month. And the symptoms are all really due to this intense cytotoxic CD8 T cell response. And that's what you're seeing on your peripheral smear. Because of that delay, the virus actually can more efficiently spread and infect many B cells, and it really immortalizes itself throughout your life in about 1 to 50 B cells per million, which sounds like a small proportion, but it's actually millions of B cells in your body. During peak infection, it's 1 out of 5 B cells are actively infected, and so there's a tremendous reservoir that gets established kind of for the rest of your life. Another interesting thing is the virus that's generated in epithelial cells is actually more efficient in infecting B cells. And B cells that have been induced to produce lytic virus in vitro are more efficient in infecting epithelial cells. So there seems to be some sort of give and take where the virus can re-enter a lytic cycle with the right circumstances and preferentially go back to epithelial cells in theory to be able to shed and infect the next host. It can also infect T cells and NK cells, which is important for malignancy, particularly with the oncogenes. Most people are actually completely asymptomatic, though, when you're infected. The symptoms, I think everyone's seen cases of acute mononucleosis is the most common presentation when you do have symptoms, but the majority of people will not have any symptoms and just seroconvert throughout their life. Another thing I wanted to point out too, we talked about there is such a huge reservoir of EBV DNA in your body after initial infection. How much our immune system actually just dedicates to actively surveilling and clearing this virus throughout your life. So up to 2% of your CD8 T cells are targeting lytic epitopes, and 1% are targeting latent epitopes. And if you think about it in terms of all the different viruses and bacteria and organisms that we can get infections with, it's a pretty tremendous amount of energy that our immune system is dedicating towards clearing this virus. This is a chart talking about several of the genes related to EBV. I'm not going to dig too deep into them. I think kind of the big ones to look at are the EBV nuclear antigen 1. That's the most commonly expressed nuclear antigen. It's in basically every cell type and latency program for the virus. It just maintains the genome. The rest of them are variably expressed depending on what kind of state you're in, whether that's acute infection, malignancy, latency. They have a lot of different functions, certainly activating other EBV genes, tumor suppression. Another really interesting one I wanted to point out is latent membrane protein 1. And what's better shown in the next slide is this actually somewhat mimics a normal CD4 T cell response in B cells by activating CD40 and kind of ushers B cells into the germinal center and then ultimately developing a memory B cell, which is what the virus wants. Ultimately, all EBV wants to do is initially infect a B cell, drive it into a memory state, develop latency, and then remain quiescent for the rest of your life. And that's what's allowed it to spread so efficiently throughout the human population. It's what allows it to evade the immune system, is it intentionally will shut down everything except EBV nuclear antigen 1 to maintain its genome. And part of that's through some of these proteins as well. So this is a figure that I took from a paper by Dr. Thorley Lawson, who is brilliant, one of the, probably the most preeminent person with EBV in the world. And it really goes over two different things. So the first on the left side is our normal humoral response to antigens. In saliva, you get antigen exposure, then a B cell, naive B cell is exposed, develops into a lymphoblast. You have interactions with your T cells, CD4 T cells through that CD40 to develop the germinal center, where you're going to start making immunoglobulins, having class switches, and then ultimately ushered into a memory B cell that will remember that antigen for the rest of your life, undergo kind of cell division, and be ready upon re-exposure to start proliferating. On the right, you can see the EBV virus, how it actually utilizes the same system. So it comes in through the saliva, surface epithelial cells, infects a B cell, and you can see that nice ring inside of the B cell. That's an episome. So an episome is, all it is a circular ring of DNA. It's non-replicating, it's not active, it's not infectious. And that's what the virus is ultimately trying to do, is to get to a B cell and kind of remain quiescent. What I was talking about too, the latent membrane protein 1, you can see how it kind of will mimic that CD40 response and actually kind of usher in the germinal center and maturation into a memory B cell. And that's all part of how the virus establishes latency. This is another one of Dr. Thorley Lawson's contributions. It's not proven, but it's a hypothesis for how the virus does switch between lytic and latent infection. A big key thing about gamma herpes viruses is it's not like alpha and beta herpes viruses. The genome is mainly maintained in these episomes, and when you're detecting it in circulation after your initial infection, it's usually going to be episomes, unencapsulated DNA, or just DNA fragments. It's not going to be that lytic virus that's infectious like the other herpes viruses. And so the left side is what we just went over, differentiation through the to a memory B cell. And what his proposal was is that you have this homeostatic balance, and then at some point, one of these memory B cells will move up through lymphoepithelium, be induced to differentiate into a plasma cell, and then that will actually induce production of lytic virus again through the surface epithelium, then into the saliva, and then on to be able to infect the next host. If you can tell, this is all occurring, though, in lymphoepithelium and other surface epithelium. It's not in circulation, and we know, and I'll go through a little bit later, that when you actually detect EBV DNA in circulation, it's not lytic virus. It's not encapsulated, which is required for herpes viruses to be able to be infectious. In terms of acute infectious mononucleosis, we talked about it's the most common syndrome when patients have symptoms, although most people have no symptoms at all. The triad is fever, tonsillar pharyngitis, and lymphadenopathy. And this was actually discovered when a lab tech working on the virus in the 60s developed acute mononucleosis symptoms. It can really affect any organ system in the body, though. Other common symptoms are fatigue, headaches, myalgias, abdominal pain. Some of the more specific complications I think we think of are splenomegaly. You can actually have rupture in about 1 to 2 per 1,000 patients with it. Of those, 50% are spontaneous, but we certainly counsel patients to avoid contact sports or things that may have a traumatic rupture. There's a characteristic rash that sometimes occurs. Rash is common on its own, but when given exposure to an antibiotic, amoxicillin's the one that's classically discussed, but pretty much any antibiotic you look at can cause this rash. It's not fully understood as well. There's a couple of proposed ideas, whether it's a true allergy or is it some sort of virus-dependent exposure between viral antigens and the antibiotic, or because you have this intense cytotoxic T cell response where your immune system is shifted towards fighting the EBV virus during acute infection, do you lose some sort of do you lose some sort of tolerance towards antibiotics that is then restored later when the immune system is kind of brought back in check? You can usually get the antibiotic later in life. It's not a true allergy, and we do see a lot of patients who have a listed penicillin, amoxicillin allergy where they may have just gotten it when they were in their youth or even childhood, and it may have been related to a viral infection. The duration of symptoms can be very wide, 3 to 54 days. And in particular, some of the response that patients have, what causes all those symptoms is nuclear antigen 3 is a particularly strong stimulator of CD8 responses to a lot of the inflammatory cytokines. And so that one is kind of pegged as one of the ones that's a common cause of kind of such intense symptoms in patients. Okay, so we'll move on to the second question, kind of how do we diagnose acute EBV? So I have a 20-year-old female who's coming to a university campus clinic with 1 week of fever, sore throat, and cervical lymphadenopathy. So she essentially has acute mononucleosis. On exam, she is febrile at 100.4 Fahrenheit with palpable splenomegaly and bilateral anterior cervical lymphadenopathy, but otherwise she appears well. So detection of which of the following below will argue against EBV as the etiology of her symptoms. So essentially, kind of what of these is going to let you rule out EBV and tell you there's something else causing her symptoms? The heterophile antibodies, the EBV nuclear antigen immune globulin, the viral capsid antigen immune globulin, early antigen immune globulin, or detection of EBV DNA in whole blood. Okay. Pull up some of the responses. So, okay, great. I didn't trick you. So the right answer is the nuclear antigen IgG, and we'll kind of go through how to really interpret these serologies because they're very complex. There's not many, other viruses or infections where you need to send multiple antibodies to make a diagnosis, and they all have pitfalls too. The most common way mono is diagnosed is still the heterophile test. It is a low affinity IgM antibody towards non-human erythrocyte antigen. If you have the right patient, so someone who's an adolescent with classic mono symptoms, it's near 100% specific. If they have a positive test with those symptoms, they have acute mononucleosis from EBV. In other situations, if it's maybe a patient who's a little bit younger, a little bit older, they don't necessarily have all the splenomegaly or the pharyngitis, it doesn't perform well in terms of sensitivity, and that's where some of our other serologies that we just talked about come into play. And it is prone to false positives in HIV, lymphoma, lupus, other viral infections, particularly arboviruses. And another point too is in pediatric patients, especially children less than 4, it may be negative, and it often is. And so it's not really reliable too in pediatric patients. The serologic testing, so if you look at any of the ELISA kits for those IgM tests, they often note that there's false positives with mononucleosis due to anything else that can really cause polyclonal plasma cell stimulation. Kind of like we talked about, at the peak, you have 20% of your B cells are infected, and that drops down to 1 to 50 per million. But you can imagine if you have that episomal ring of EBV DNA, if something else causes that plasma cell that B cell, memory B cell, to differentiate into a plasma cell and start to produce antibodies, you're going to have a lot more EBV DNA. You might have more EBV antigen. And so you could have redevelopment of those IgM antibodies. And that's why these tests are really hard to interpret, particularly the IgMs, because there's such a huge reservoir of EBV antigens in your body for the rest of your life, and those antibodies can turn positive again. The viral capsid ones are lytic phase antibodies. They are present in 100% of patients with acute mononucleosis. It can persist usually for about 2 months, but in some patients it'll last even longer than that. The IgG is lifelong. This is actually, if you order the test here at Tampa General Hospital, what our machine will run is viral capsid antigens. You can also send the early antigens. These are not often tested because there's very little clinical utility we have with them. Some antigens are more associated with certain cancers than other. That's kind of the main thing to know about it. And then the nuclear antigen, is the latent antigen. So it really will peak 3 to 4 weeks after symptom onset. And remember, it takes about a month before you start having symptoms anyway. So at this point, it's 2 to 4 months after infection. And that's why it's really helpful to rule out acute infection. If you can show a negative nuclear antigen with positive viral capsid antigens, and even better, if you can show seroconversion in 3 to 4 weeks of that nuclear antigen, that confirms your diagnosis. It is supposed to persist lifelong, and it kind of stabilizes with a pretty reliable titer after your initial infection. And what it really is just an antibody towards one of the 6 nuclear proteins that are present in latent infection. This is a graph going over with that. A lot of those words we're just saying. The main thing to take out of it is if you see the nuclear antigens, the purple dotted line. It develops later during the infection, certainly not very acutely, and then stays detectable for the rest of the life and through convalescence. So key points for testing. These serologic tests are very useful for acute EBV. Again, if you can show seroconversion with your nuclear antigen, you've essentially made the diagnosis. After initial infection, they're very hard to interpret because a lot of that stimulation of B cells that may have EBV DNA that's just in an episome and not active can have re-exposure of antigens and development of IgM antibodies. There is a phenomenon known as chronic active EBV, and I'll talk a little bit about that, but it's a very different disease. It's not just detection of antibodies, because you get detectable antibodies for many other reasons, and some of our IgG antibodies, the nuclear antigen, the viral capsid, are going to stay positive for the rest of your life. In terms of the PCR assay, there is a place to send an EBV PCR, and it's mainly after transplant in terms of being able to predict post-transplant lymphoproliferative disorder. We'll go into it, but usually what you're detecting, like we were talking about when we went through the life cycle, is episomal DNA, unencapsulated DNA. You're not detecting lytic virus in circulation, and so it's more helpful to kind of say, what's the burden of EBV genetic material? Do I have some sort of clonal expansion of an EBV infected cell? And that's really what PTLD is. And other scenarios where it may be helpful, if you've got a patient who's got lymphadenopathy of unclear etiology, maybe an effusion, and you're really worried about lymphoma or some EBV-related malignancy, a very high level of EBV DNA can help point you towards that diagnosis. But I did want to show this chart just showing how common shedding is in terms of oropharyngeal samples. We talked about the germinal center theory from Dr. Thorley Lawson, that you have lytic reactivation in lymphoepithelium and then shedding. In healthy adults, it's over 10% of the population is actively shedding at any given time, and that number goes up the more immunosuppressed a patient is. But this isn't in the circulation, and so certainly having DNA detection in your blood doesn't really equal disease, and it's more prediction of a clonal expansion of an infected cell line. Another challenge we have with EBV is we don't really have good guidance about which samples you should test. Certainly plasma or serum, you're going to be looking more for free DNA, and mononuclear cells, it's going to be cell-based. Whole blood, you're going to get both. In acute mononucleosis, I care more about the plasma or serum, where I should have high levels of viral DNA as it's going on to infect other cells. But in post-transplant lymphoproliferative disease, for example, I care more about cell-based DNA, and so I shouldn't really be testing plasma or serum, but that's actually what most transplant centers use because it's easier, and it's kind of the available assays. We don't really have, these aren't standardized either. If I send this test off to ARUP or Viracor or Moffitt, I may get 3 different copies per ml, and we're just now starting to establish international units like we have with CMV, but it's still not standardized in terms of which sample we send or what DNA threshold matters or how to interpret it from lab to lab. And then certainly even beyond that, a clinical utility for when I can make an action based off of a level. This is from that same study, just kind of a nice picture I really like, showing when EBV DNA is detected in certain clinical scenarios, what are you actually detecting? So at the top, you have acute mononucleosis. The virion is the purple circle with a little bit of a red ring around it. But even in acute mononucleosis, a large percentage of that DNA is still unencapsulated DNA or episomes. After your initial infection, though, it drops precipitously, and almost everything you're detecting is episomal or unencapsulated DNA or just cell-based products. The one exception, I think, would be some of the nasopharyngeal carcinomas and other epithelial tumors, where you can still have detection of virion. It's a minority, but it is still there, and you can see that at the very bottom. And that's likely due to the virus getting arrested in the incorrect cell type, an epithelial cell. It doesn't make its full transition into a memory B cell, and then some oncogenes are used or turned on where it then develops into a carcinoma and then is actually still shedding lytic virus because the virus in an epithelial cell wants to have lytic expansion and then go on to an infected B cell. This has also been studied in PTLD. Those patient samples lack EBV RNAs as well as latent membrane protein 1 in histopathology, which suggests that this is a latent process. It's not a lytic process. And so the term reactivation with EBV is not the same as alpha and beta herpes viruses. When you say reactivation, what you're really talking about is clonal expansion of an infected cell line. So it's a little bit of a misnomer. It is still used in papers and things like that, but it is really important to when you're approaching gamma herpes viruses, EBV and human herpes virus 8, that reactivation is more just you're detecting cell products and episomes. You're not detecting an infectious virus. In terms of seroprevalence, this was a study of patients and kind of just checking antibodies by age group. By the time you get to age 40, it's near 95% seroprevalence. And that kind of was what the first question was getting at. A patient who's 38 years old almost certainly has had it by that point. The highest rate of seroconversion in adults is kind of adolescents. So that in the US, the 15 to 24-year-old age group. This was actually a study in England of students entering college, and a significant proportion of them seroconverted in the first 7 months. And most of those actually had symptoms. Some uncommon complications that can be life-threatening: critical airway obstruction, particularly from the lymphadenopathy. You can also get devastating neurologic complications: Guillain-Barré, meningoencephalitis, transverse myelitis. It can affect the heart tissue, the liver, really any organ in the body. And there is an association with Lemire syndrome, or septic thrombophlebitis of the internal jugular vein in the setting of a deep space infection. Classically, with EBV, it's associated with Fusobacterium. The reason is not fully understood. It is similar age groups, but there is a clear association between EBV and that bacteria causing Lemire syndrome. In terms of treatments, most patients just require supportive care. 95% recover without any sequelae. The antivirals have in vitro activity. They've actually been shown to decrease oropharynx shedding of the virus, where you do have, through that germinal center theory, some sort of lytic process. All of our antivirals we use predominantly either act directly or indirectly on DNA polymerase, and because most of what you're detecting after that initial infection, or even once you develop symptoms, is a latent process, and your symptoms are due to the CD8 cytotoxic response towards infected cells, antivirals just really don't have any benefit. And that's also true of human herpes virus 8. Steroids also haven't really shown a benefit in acute mononucleosis. In critical airway obstruction, they're used sometimes just because of airway edema. And I think kind of that's still just mainly the key point, is we haven't really found a scenario where antivirals will have a benefit, and it's really because it's a lytic process at that point. I mean, a latent process, I'm sorry. Chronic active EBV, what this is essentially you have your acute mononucleosis and then just leads right into a persistent syndrome of those symptoms. The pathophysiology of it is a lymphoproliferative disorder of T or NK cells, and it's actually required not just to have that, but they have to be shown to be infiltrating vital organs, usually on a biopsy specimen. This can progress to a very aggressive high-grade lymphoma. Many things have been tried to treat it, but unless you're able to get to a stem cell transplant, those patients do very poorly, and the prognosis is very poor. For HLH, this is a pathogenic lymphocyte and histiocyte activation, usually in the setting of acute EBV, so it's more of a pediatric and adolescent patient population issue. You get essentially the virus infected a T cell population, and you get a monoclonal expansion of that population, a lot of cytokine overactivity. leading to the HLH. It can happen with NK and B cells, but classically it's with T cells. Later in life, you absolutely can have HLH due to an EBV-related malignancy, particularly if you've got a T cell or NK cell lymphoma that is has EBV DNA in those cells through an episome or for however the genome's maintained. The part there is it the HLH due to the cancer, or is the HLH due to some sort of antigen from the expansion of that EBV DNA? It's not infectious virus. It's not lytic. We know that, but we know that you can get it in certain cell lines that are infected with EBV later in life. And so that's something to be aware of too. And certainly a very high level of DNA in the blood may suggest that in the right clinical scenario. But the key point for that is it's not a lytic virus, and that's why antivirals really won't help with EBV-related HLH either. I kind of just talked about that, but there's other clinical scoring tools to kind of help predict HLH. The H score is one I use commonly. This is a nice picture showing cells that are consuming red blood cells from Wikipedia. Treatment for mild cases is corticosteroids, IVIG. There are standardized regimens. There was a landmark trial, HLH 2004, that utilized dexamethasone and etoposide. Cyclosporin was historically added to that, but this study essentially looked at just dexamethasone and etoposide versus the historical treatment and showed no benefit of cyclosporin. If that fails, the next step is usually rituximab, or in the worst cases, stem cell transplant. Okay, so this should be our last question before we kind of move into PTLD. A 36-year-old male with relapsed refractory AML is seen 2 months after a haploidentical allogeneic stem cell transplant. That's his conditioning regimen. He's CMV donor negative, recipient positive, EBV donor positive, recipient positive. He's referred for consideration of rituximab due to detection of plasma EBV DNA. And so the question is, at what level of EBV DNA would you administer prophylactic rituximab to reduce the patient's risk of developing PTLD? Any detectable DNA, over 5,000 copies, over 10,000 copies, 50,000, or regardless of the level, only treat after you've developed disease. Okay. Okay, so very interesting split. I think the majority would wait until we have disease. There's no right answer here. This is something that the jury's still out on and that we need a lot more research to determine. It kind of is center specific, but I'll go over a lot of the data that we have and then the guidelines to kind of help us out. So post-transplant lymphoproliferative disease essentially is just an abnormal growth of EBV positive B cells. It can also be NK or T cells, but B cells are the reservoir for EBV in for most of the genome, and so that's typically what you see. It can range from any number of things. So benign polyclonal hyperplasias, where you've got multiple different cell lines that are expanding, or very aggressive monoclonal populations, or even lymphoma. The crux of it is really just loss of T cell surveillance, and that's been shown in murine models. And then we know from patients, if your conditioning regimen is T cell depleting, particularly T cell specific, you're at a higher risk of developing PTLD. It's different if it's solid organ transplant or stem cell transplant, and solid organ transplant is typically a host derived PTLD, whereas in stem cell transplant it's typically donor derived, which is the opposite of some of the other herpes viruses like CMV, for example. So the types of PTLD, these are the 2008 WHO definitions, which are still used. It kind of what we were talking about before. You have early polymorphic or even up to very aggressive lymphomas, and they're all treated differently based on kind of what's there, and that's why histopathologic diagnosis from tissue sampling is critical. So starting with solid organ transplant, it's typically a recipient-derived process. It's often disseminated. You can have donor-derived PTLD in solid organ transplant, but that's often restricted to the actual allograft itself. In the United States, 20% of PTLD is actually EBV negative, which is important to remember. Worldwide, that's up to 30%. It usually occurs during the first year of transplant. That's up to 80% of cases. And then at the 10-year mark, overall incidence is about 1%. But you can see it varies dramatically based on the type of transplant. A lot of that goes into what's your immunosuppression, conditioning regimen, things like that. But our small intestine transplants, it's up to 32% of patients will develop PTLD, which is a pretty substantial number. These are some risk factors from a great study in the New England Journal in 2018. The two I really wanted to highlight is an EBV mismatch. So recipient negative, donor positive is an increased risk. And then also T-cell selective conditioning regimen. So anything that's really knocking out your T cells, especially if your B cells are relatively preserved, is going to increase your risk. The other ones listed at the bottom, they're proposed. There is some data for it, but they're kind of, the evidence isn't as strong as the two I mentioned. So in terms of our transplant patients, the goal would be, how can we find good predictors of development of PTLD and then be able to act on them? This was a study in the 80s of liver transplant patients at a pediatric hospital. They took, basically all the patients had biopsies. And then once patients developed PTLD, they went back and looked at their biopsies to see in those who developed PTLD compared to those who did not, which markers may help kind of give a prediction. The mean onset was 12 and a half weeks after their transplant. And the main thing here that they found was those EBV encoded small RNAs. If you had those, you were more likely to develop PTLD, but it certainly wasn't 100% sensitive. It wasn't, 100% specific. 10% of the patients who never had PTLD had detection of these RNAs. And in those with PTLD, still a very large proportion of them did not. And so it can suggest that you may have an increased risk of PTLD, but it's still, the clinical utility is hard because it's not a universal or kind of rule in, rule out test. The presentation of actually PTLD after solid organ transplant is usually constitutional symptoms: fevers, chills, weight loss, fatigue. The patient may have lymphadenopathy or organ failure. And if you see that in a patient after a solid organ transplant, you should certainly be worried about PTLD, particularly based on their risk factors. They may have masses if it's in the graft itself that may key you into donor-derived, but it can be disseminated in really any tissue in the body. There was for a while, we were trying to find, how do we interpret the viral load? So 10 to the 4th was proposed as high risk. But especially in some of our high-risk patients and small bowel transplants, you can have sustained levels that high for months and not go on to develop PTLD. So it's hard to kind of establish a threshold. And we do need a lot of future research and actually standardization of these assays to figure out who would benefit from an intervention. And kind of going along with the high load definition. So this study picked 16,000 copies on over half of samples obtained over a 6-month period of asymptomatic patients. So by no means is this a standardized protocol, but what they found is if you had persistently elevated EBV DNA, you had an increased risk of developing PTLD, which is intuitive, given that a lot of this is in EBV infected cells. It was still not a majority. It was 45% of patients, and those who did not, who had less than that on less than 50% of samples, only 5% went on to develop it. In terms of preemptive therapy, so we know that it's usually B cells, so certainly rituximab is an attractive option in terms of preventing and or treating PTLD. This was a prospective study of 299 heart allografts in France. They had ATG conditioning, so a very high risk with that T cell depletion. Essentially, they said if the EBV was over 10 to the 5th copies twice over a month or one time over 10 to the 6th, they administered rituximab. What's important for every single one of these studies is, like we talked about before, for standardization, which sample was used: plasma, whole blood, peripheral blood mononuclear cells, and then which primer as well, because certain antigens are going to be expressed in certain cell lines and certain latency programs, and some won't. And so they used a thymidine kinase primer. They had 9 patients overall who received rituximab, all became undetectable. They only had 1 case of PTLD, though, in their study, which kind of limits their conclusions. And in the intention to treat analysis, there was no statistically significant difference. They excluded one patient and kind of had a per protocol analysis where they came up with a number needed to treat of 38, but it's not very robust data to show that there's a clear benefit of rituximab, and we definitely need additional studies to kind of figure out which population we can provide the best benefit for. So the American Society of Transplantation, working with its ID community of practice in 2019, did put out some guidelines. They basically say that there's no recommendation they can give regarding a threshold approach. They talk about a lot of the same problems that I've mentioned throughout the talk. They also essentially say there's no evidence to give rituximab in high risk or elevated EBV levels if there's no PTLD. The question I gave you was a stem cell transplant patient. We'll go through that a little bit, but at least in solid organ transplant, kind of the national guidelines don't really have much that they can offer you other than saying it's an increased risk, but we can't tell you what to do about it or the set threshold to act on it. It's really become almost a center-specific approach because of that, and certainly depending on where you practice, you may have different approaches or which allograft the patient has. The mainstay of treatment, though, in solid organ transplant is actually reduction of immunosuppression. This was a great study in 2001 in patients with PTLD. In those 30 patients, 63% of them had complete remission with reduction of immunosuppression alone. The protocol will vary based on your transplant center, but a lot of times it's stopping the calcineurin inhibitor, the anti-metabolite, and continuing the patient's prednisone. In that study, if you just focused on patients who had a normal LDH, no evidence of organ dysfunction, or single organ disease, certainly some of those were probably actually donor-derived if it was the allograft itself, reduction of immunosuppression cured 89% of them. If there is CD20 expressed in the lymphoproliferative disorder, or you could potentially give rituximab. If it's an aggressive lymphoma, they may need cytotoxic chemotherapy. Local disease sometimes gets radiated, or CNS disease. What's becoming more available is actually EBV-specific cytotoxic T cells. There's more research in stem cell transplant, I'd say, for this, but it is an emerging modality for solid organ transplant. And again, there's been no evidence that antivirals have any benefit in this process because it's a expansion of latently infected cells. It's episomes. It's not lytic virus, and so that's why the antivirals really won't help. In terms of stem cell transplant, it's a donor-derived process. Again, it's just loss of T cell surveillance. High risk, we know, is T cell depletion, especially if you spare your B cells, or increased immunosuppression. Certainly in stem cell transplant, a lot of times, your T cells are much more immunosuppressed than in solid organ transplant, just by the nature of a stem cell transplant. It's not uncommon to develop DNA-emia, and a lot of times it just resolves on its own. But the highest risk is ATG and that T cell depletion, and it can happen in up to 25% of patients who get ATG as part of their conditioning regimen. And that's what this study looked at in 2001. It was a multi-center study of several patients with T cell depleted allografts. One of the centers actually gave ATG, and they kind of just looked at the rates of development of PTLD on the right, and you can see it's 25% if you got a T cell depleted graft with ATG, and then substantially different from your non-T cell depleted grafts on the other side. EBV reactivation, or just detection of EBV DNA. Like I was saying, it's not reactivation in the sense of lytic virus, but the terminology persists in the literature still. It's really kind of the episomes and unencapsulated DNA. Is up to 75% of patients with T cell depletion and ATG. But it's important to note, it's still only a minority of those patients that go on to develop PTLD. And so that really has to come into play when we're deciding who to treat or not, that only a minority are going to develop it. We talked about there's a lot of variability based on which primer you use, which sample you use. Higher levels are more likely to correlate with development of PTLD, but we don't really have a good cutoff or standard to know where we need to act on it. In this particular study I just showed you, no patients with less than 1,000 copies developed PTLD, despite a very high risk regimen with T cell depletion and ATG. And so that kind of became a cutoff for a while. We'll go into a little bit of the other studies why that might be a problem. Certain risk factors For PTLD and stem cell transplant, it's a lot of the same things as solid organ transplant. Other ones I'd highlight that are more unique, cord blood transplant itself. Those are really T-cell depleted allografts just by the nature of a cord blood sample. HLA mismatch if they have severe GVHD. There are some things that actually protect you though from PTLD. So if you get rituximab for whatever reason prior to transplant, it's protective. If you get cyclophosphamide as part of your GVHD prophylaxis, that actually is protective, which is a little bit counterintuitive because that can increase your risk of other herpes viruses like CMV, HSV. But the reason is really because the gamma herpes viruses are just so different from the alpha and the beta herpes viruses. And not surprisingly, early reconstitution of your T cells at day 30 is protective. In terms of prophylaxis studies, this was from 2012. Retrospective, they gave 55 stem cell transplant patients rituximab on day 5 and then compared it to controls. All of them received ATG, so this is a very high risk of developing PTLD, up to 25%. What you can see in here is the controls actually had less than that 25% of the Van Esser study. It was only 14. There was only one case, though, of PTLD, and so they weren't able to have a statistical analysis. The rituximab group had 0 compared to 1 in the controls. There was certainly less EBV DNAemia, over 1,000 copies. There was less high grades of GVHD, which was interesting. But the main thing to take away, I think, is the overall survival at 180 days was not statistically significant. It trended a little bit higher in the rituximab group. They didn't follow them for a full year, which is a fair criticism, but at least in those first 180 days, there didn't seem to be a clear mortality benefit. Another study, this is more just for why we have to be really careful about giving rituximab. It's not a benign medication. It's essentially a monoclonal antibody targeting our B cells. It was in 2011. They took 102 match-related donor transplants with some pretty T-cell depleted transplants, so high risk of PTLD. They got rituximab for other reasons, graft versus host disease, one of them for PTLD and one for an autoimmune hemolytic anemia. The main thing to take away from it, though, is that there were substantial cytopenias for up to a year afterwards. 16 to 17 patients had severe neutropenia still. 14 developed recurrent bacterial infections, 6 of them significant fungal infections, and 5 actually died of invasive fungal pneumonia. So, 5 out of 17 is a substantial proportion, and we have to kind of keep that in the back of our mind when we're evaluating the patients. In terms of preemptive therapy, so essentially waiting until you detect EBV DNA and then electing to give rituximab, which is what that question was kind of getting at when we started. This was a study from 2012. They took partially matched allo transplants, and some of them were given rituximab for EBV DNAemia. They didn't publish the level, and there wasn't a supplement I could find, and so I'm not sure if it was just any EBV DNAemia or a certain cutoff. One of them still developed PTLD, and then they matched it to 52 controls. The main thing to take away from it is there's a higher rate of infections, probably getting rituximab, which we already kind of talked about. The graphs here moving from left to right are bacterial, viral, and fungal infections. The error bars overlap. There's not a ton of patients in this study, but you can see that it's starting to separate, and it should give you kind of pause that, I shouldn't give rituximab to everybody with EBV detected in the blood after a transplant, because it happens in up to 50% of patients. Most of them it's going to resolve. And even in those who have potentially higher levels, most of them aren't going to develop PTLD. Another preemptive study from 2020 in France looked at 219 non-cord blood transplants with ATG. They monitored EBV DNA weekly. They defined reactivation as 2 consecutive samples over 5,000 international units. There was 117 episodes of reactivation. They matched 69 of those to a control group of 112 patients. These are their baseline characteristics. Nothing's statistically different. I would highlight the disease status, kind of 3 from the bottom on the right. In the rituximab arm, these were sicker patients, so there's more high-risk patients. It was almost statistically significant. And in terms of giving rituximab, if you receive rituximab, you were more likely to require IVIG and immune globulin replacement. That was statistically significant. The overall survival, though, actually was worse in the rituximab arm. It wasn't statistically significant, but it was, at 2 years, only 59% of the rituximab patients were alive compared to 82% of the controls. I just told you there were more high-risk patients in the rituximab arm, and that's certainly a confounder. But it again should give you kind of pause that we really got to be careful and make sure we're doing the right thing by our patients by identifying who's going to benefit from rituximab. And this last study is one, probably the best one in terms of figuring out a cutoff for us to be able to use. So it is a retrospective cohort analysis of stem cell transplant, solid organ transplant, and then about 858 patients that didn't have either who developed EBV DNA detection or EBV DNA anemia. And then they evaluated for risk factors for post-transplant lymphoproliferative disorder. DNA anemia occurred in 18.6% of the transplant patients. They kind of reported everything as an aggregate. They didn't really separate out in solid organ and stem cell, which is a fair criticism because we've kind of been over how it's a little bit of a different process between solid organ and stem cell. They also used 3 different plasma sampled assays over the study period that they claim they calibrated, but whenever you start talking about that, it gets a little bit dicier too in terms of which, does the value of EBV DNA on that first assay equal the last assay, and then kind of how they did the calibration process. So main thing to take away from it is detection of DNA itself is pretty terrible at predicting PTLD. It only had a 47% sensitivity, positive predictive value of 12.5%. If you never developed EBV DNA anemia, it had a pretty good negative predictive value, which makes sense. Most of PTLD is EBV related. In terms of certain thresholds and cutoffs, so DNA between 501 and 5,000 copies had an odds ratio of 2.03, but you can see it crossed 1, and so it wasn't significant. But over 5,000 copies, there was a significant increased risk of developing PTLD. And again, this is the aggregate data, so stem cell and solid organ transplant. They did note beyond that 5,000 copies per ml threshold that it didn't really improve their receiver operating characteristics curves. So it's at least providing us a little bit of data of, okay, maybe there is a threshold where we need to start acting. In terms of our own institution, so Tampa General, it's program specific, depending on your allograft. It's actually not even explicitly stated in our Tampa General solid organ transplant infectious disease guidelines. That's very much in line with the American Society of Transplantation, which says that, we can't really give a set threshold or even give recommendations on rituximab. At Moffitt Cancer Center, we actually just updated these recently. We now will monitor patients up to day 100 if they have high risk grafts, so T-cell depleted, mismatched, unrelated donor, high grades of GVHD. The threshold that we set, because certainly a lot of these patients will become undetectable or downtrend, is having over 3,000 copies per ml over a 2-week period. And over 15,000 copies once could be an indication to go ahead and start looking for PTLD. It's an in-house plasma-based assay, which we talked about a lot earlier in the talk. Maybe not the best assay if you're looking for cell-based DNA. You might want to be looking at whole blood or peripheral blood mononuclear cells, but it is the easiest where you get the most rapid results. And so that's the one we use in most of the other studies I presented. A lot of them use plasma-based as well. And so kind of in summary for stem cell transplant, there's no clear data that thresholds of 1,000 or less are associated with higher rates of PTLD. There's a lot of risk with rituximab, and we have to be cognizant of that when we're administering it to patients. At thresholds of 5,000 copies per ml, for stem cell transplant, rituximab didn't seem to have an improved 2-year survival. Now, that last one I showed you in plasma, so assuming you might have a higher, it's not standardized to whole blood, right? It's plasma versus whole blood. For the aggregate of solid organ and stem cell, they found a benefit. Certain risk factors, T-cell depletion, cord blood transplant, carry risk regardless of the EBV level. And we have so much variability in these testing platforms, we need a lot of research to kind of standardize that. But I will leave you with this. This is a study of patients, 406 allotransplant patients in Finland. 14% of them had detectable EBV DNA at least once. At the cutoff of 5,000 copies per ml, which they had 22 patients overall, every single patient died. And 15 of those had PTLD on autopsy. And so it's a good argument that, there's a level probably in there somewhere where we should consider giving these patients rituximab, and we just kind of haven't fine-tuned where that level is yet. These are guidelines from the European Conference on Infections and Leukemia. For time's sake, it kind of goes through a lot of what we have already talked about, that they say that it is reasonable to give rituximab preemptively to prevent PTLD, but they can't tell you which threshold you should initiate therapy. They talk about doing 1 to 4 doses weekly until the DNA becomes undetectable. You should also do reduction of immunosuppression. Cytotoxic T lymphocytes have a lot more data, and stem cell transplant are a potential option, and they kind of go through other things. Antivirals certainly still don't help, and that's mentioned in here as well. Some other topics I wasn't able to talk about because there's a lot with EBV: hairy cell leukopplakia, which is a non-malignant lytic replication. You might have an oral lesion, immunosuppressed patients, classically HIV/AIDS. EBV in general is associated with 1.5% of all cancers, not necessarily causes, but cells that have EBV DNA in them. Chimeric antigen T cell therapy is an emerging therapy for lymphomas and other types of malignancies where we're not really quite sure what the PTLD risk might be, but it is something we kind of have to keep an eye on and see if there's any role that EBV has in those patients. There are associations proposed with autoimmune diseases such as multiple sclerosis. The prevailing thought is there's some sort of epitope mimicry where you get an autoimmune response to one of the EBV antigens. Alzheimer's disease, there's kind of mixed studies. Some studies suggest that EBV seroprevalence increases your risk. Some say that there's not really a difference. And then vaccines, too, the glycoprotein 350 is the most expressed glycoprotein on EBV. It's actually essential for EBV attaching to B cells through that CD21 receptor. And so it's become a very popular vaccine target. There are some animal models that suggest you may be able to block acquisition of EBV, but in phase 1 and 2 human studies, it seems to protect you from developing symptoms, but not actually preventing infection overall. And so a lot of research is still going into this because if you think about it, the good that could be provided to humanity, if you could prevent acquisition of EBV, which is implicated in 1.5% of all cancers, you could potentially prevent a lot of cancers, and similar to kind of what we are going for with HPV, and then certainly even treating things like Hep C and things like that. So take-home points: antivirals, it really any stage of acute EBV have not been shown to have a benefit, and the reason is almost always what you're dealing with is latent viral gene products, either in the episome or unencapsulated DNA, or in your acute infection. By the time you develop symptoms, which are due to your CD8 T cell response, it's too late. The virus has already entered mostly a latent phase, and really all the antivirals can do is decrease oropharyngeal shedding. We have a lot of problems with our assays, particularly the DNA in the blood. There's no standard. What you're detecting is almost always cellular, episomal, or unencapsulated DNA. It's not like alpha or beta herpes viruses. But with that germinal center theory, we do know at some point you can have shedding of lytic virus. And the thought is that you have a memory B cell that enters into differentiation to a plasma cell and starts making lytic virus to go on to the next host. It's just not in circulation. That's kind of a unique thing to gamma herpes viruses. HHV8 is thought to be the same way as well. And so the DNA assay really has limited utility outside of transplant populations in terms of predicting PTLD. But even then, it can occur at low levels or be absent in extremely high levels. So we really need a better way to predict who's going to develop PTLD outside of just the DNA PCR. If you are looking to diagnose it, if it's the right patient population, classic symptoms, your heterophile assay is going to be the best one. If it's more atypical, not the classic symptoms, then you may be using your capsid antibody or your nuclear antigen antibody. And then in patients who are high risk, rituximab likely does have a role because most of these are CD20 positive B cells that are having clonal expansion. We just need a lot more research to figure out who's going to benefit for that, and keeping in the back of our mind the potential negative side effects of rituximab in terms of evaluating the optimum patients to treat. And I think that's all I have. So I'm happy to answer any questions, and thank you everybody for joining today.
Guy, that was wonderful. Where, as we look to the future, what unique approaches, other than say rituximab, do you see in dealing with this dangerous virus?
I think the future of treating EBV in terms of PTLD is going to be cytotoxic T cells, especially in stem cell transplant. We've got decent, even now, phase 1 and 2 trials, and you can get it. I mean, Baylor, NIH have programs where it can be used to treat PTLD and to a tremendous benefit. I think the next step, too, that people are starting to look at is actually giving some of those products to patients going into their stem cell transplant, particularly if they're high risk, in order to reduce the risk of developing PTLD. Those are being combined with other herpes viruses too, like CMV, and to basically decrease the rate of their negative consequences. And I really think that's where the field is going, and is cytotoxic T cell therapy.
Thank you.
Dr.
It's
Handley,
time.
there's a couple of questions in chat. Can
Sure.
you see them?
I maybe have to end the slideshow. Let's see.
If not, I can read them to you.
Sure. Maybe reading is, yeah. I don't want to mess it up.
Okay, so the first one was, can you talk about your experience with using mapilimumab? Mapilimumab. I'm not going to pronounce this right.
For EBV?
In the population with EBV and HLH.
HLH, yeah. I haven't personally used it. I know it is used a lot of times in the pediatric populations. It's more for treating the HLH than EBV gene specific products. I don't think it, there is, especially in like pediatrics, you can have some benefit and more for the inflammatory process. I don't think it has really much to do with the EBV gene products itself, though.
And then Dr. Ledford wrote, do episomes replicate during clonal expansion of cells? Not clear to me why the episome would replicate and why the levels increase with clonal expansion.
Great question. And the answer is no, episomes do not replicate. So what you think happens is you develop one episome after it infects a memory B cell, and then all the EBV virus wants to do is to remain quiescent for the rest of your life at that point. And that's what it's allowed it to persist, evade our immune systems, and infect 95% of people by age 40. At some point, what can happen is you lose, and our immune system does this all the time. Your T cells will see something going on with the B cell and induce apoptosis or clear out that cell line. You can have some sort of oncogene turn on. You can have some sort of inappropriate clonal expansion of a memory B cell. And that will cause multiple copies of the episome to be made just because the cell's dividing and it's making a copy of that episome. It's not happening in the cell itself. What Dr. Ledford's talking about, you're not getting like 50 episomes or, logarithmic expansion of that. It's just you're getting expansion of that cell line that has an episome in it. And that's what you're seeing when the EBV DNA goes up. It's just a lot more cells in that population carrying it.
Hi, doctor. Can you hear me?
Mhm.
Yeah, but the lymphoma cells carry multiple copies of DNA, EBV DNA. Right.
So each individual. So I guess if you're checking the blood, you're going to have multiple lymphoma cells. But if you check each individual cell, they can sometimes have more than one or two episomes. But it's not like the episome itself is dividing in the cell.
Actually, they have more than 80 copies, and the MNA1 binds to all of them.
I guess what you can have multiple copies of different EBV gene products for sure, but you're not getting replication of the EBV genome where it's going to dramatically increase. You may have a cell that got, for whatever you're standardizing your assay to, which is kind of the problem. We don't have standardization that is leading to 80 copies in that cell. But over time, unless that individual cell isn't going to produce a substantially more amount of EBV DNA, you may get more copies of the cell, and then the DNA total volume goes up. But it's not like you're getting a logarithmic expansion of an episome in one cell line or one cell itself.
Thank you.
Sorry, I know that's the biggest problem we have with a lot of our testing assays is that you're not, when you test it and you're getting copies per ml, it's not necessarily a reflection of what's going on at each individual cellular level. But you are right. You can have multiple copies in one individual cell line. It's not, classically it's described as one episome. That's not actually true. You're right about that.
Thanks.
Hi, hello.
Thanks.
Yeah. So you said, as with EBV, it's also same for HHV8, which is HV. So as far as my understanding goes, during lytic reactivation, due to whatever conditions, stress or immune suppression, there are new viruses being produced from the infected cells.
Yep.
Is that true?
Yeah, so we know even less about HHV8 than EBV. We know that when you do have stress and shedding, you do get lytic reactivation. The thought is it happens in a similar place as EBV, but even less is known about that. So in the saliva and oral epithelial tissues.
Yeah.
And we also know that if you check the circulation or plasma, what you're detecting a lot of times is not lytic virus either. It's just gene products. And so the HHV8 is definitely different. Seroprevalence in the US of that is 5%. Some places in the world it's up to 80%. But because of they're both gamma herpes viruses, they're thought to behave in a similar way, but there's far less known about HHV8 than EBV.
Okay, thank you.